Hello, good evening, everyone, and welcome to the EUROGEN webinar series. Just before we get going, I want to take a couple of minutes to explain a little bit about what a European reference network is and does. There are 24 European reference networks, all created by the European Commission in 2017, and they all deal with different medical areas for patients with rare and complex diseases. So really where the medical expertise is rare. And in EUROGEN, we cover rare urogenital diseases and complex conditions. And our aim is to deliver quicker specialist evaluation and more equitable access to high quality diagnosis, treatment and care for patients with rare urogenital diseases and complex conditions. And they all need highly specialised surgery. So some of our activities, I hope you saw from the slides at the beginning, we have a tool called the Clinical Patient Management System, which has just been upgraded in collaboration with IBM. And we can do safe and secure virtual consultations across borders. So if any of you have a tricky case, please don't hesitate to get in touch. We'd be delighted to help. We also work on clinical guidelines, training and education activities, and we have a EUROGEN registry. And this is very exciting because it will bring together fragmented data on patients with these rare diseases, and we should be able to do more robust research and have evidence for the clinical guidelines. So without further ado, it's an absolute honour to have with us here this evening Professor Prof Chapple, who actually was the person who founded the European Reference Network, EUROGEN, many years ago now, Chris. Of course, he was a surgeon in Sheffield Teaching Hospital NHS Foundation Trust with a hugely long career in functional urology. He was also Secretary General of the EAU for 8 years. And I know that he has a very, very long-standing research activity into tissue engineering. So I'm absolutely fascinated to listen tonight, Chris, to hear about tissue engineering as applied to the urinary tract. Is this a reality? So, Chris, it's an honour to have you here, and please, you have the floor.
Thank you very much, Michelle. I'm extremely honoured to have the opportunity to address the group today. And without more ado, I'm just going to share my screen if I can find the right button. It's a great honour to address you this afternoon or evening, wherever you are. And what I'm going to discuss is the subject of tissue engineering. It's a term which actually has got a lot of appeal because it sounds rather science fiction-y, doesn't it? But the question is, what are we actually talking about? I have conflicts of interest largely relating to my long-standing work in clinical pharmacology. I mention one in particular, which is not pharmacological, which is a company just founded by the university and the hospital called Pelvishaw, which is to develop an implant, which I'll be talking about. But the work which I'm going to present, we've never received any commercial sponsorship for any of this work. It's all through grants, academic grants. And this organization hasn't yet been founded, but will be by the university and hospital. The term regenerative medicine is often used as being synonymous with tissue engineering. And what we're really talking about is a combination of cells, substrates, in other words, matrices, and the combination of both. And obviously that has to take account of the addition of various factors which allow the cells to develop and grow on the underlying substrate, the basic foundation, if you like. And what you really do need is an interdisciplinary team to deal with this, because we're talking about engineering. When you're talking about the underlying matrix, you need to understand the nature of the tissue that you are developing, and you need the clinical input. and you need biological input where appropriate, as you will see during the discussion. What we're talking about is to actually use cells to produce a new tissue or to provide a function in the body by growing those cells. Obviously, cells are essential. The smallest organisms are unicellular, for instance, bacteria. And of course, they're the building blocks of life. We're multicellular, and we have 100 trillion cells, which are differentiated into many different structures. And of course, the largest cell in the world is the ostrich egg. Of course, you have cells of different types. You've got the pluripotential cells, which can develop into any tissue, and you've got more differentiated cells. And the problem with using pluripotential cells is you don't know actually what they're going to necessarily develop into when you set them going. And so we tend to avoid those and look at the more differentiated cells, which can actually be then grown up in a cultured situation and then implanted into the body. So we don't really want to go for these basic embryonal stem cells, which can develop into 300 different types of tissue. You want the more mature stem cells. These are shown here because obviously the others develop into all the tissues in the body, which you can see below. So what are we actually trying to do? What you want to do, if you're going to grow something for implantation into one of us, is a cell from the body, a biopsy. These cells are then grown in isolation in appropriate culture media and expanded. Having done that, then you combine them with an underlying matrix, and of course you may need various stimuli or bioactive agents to be added to produce a finished tissue, as shown there. So the fundamental question you've got to always consider is which cells you're going to use. As I've mentioned, you want more differentiated ones. What is the scaffold or matrix you're going to use? And what's the tissue you're trying to produce? So let's look at the evidence as you go through the whole urinary tract. Obviously, kidney problems, kidney failure, is an important clinical issue. We're all familiar with renal transplantation, and of course it'd be great to be able to produce a new kidney. A number of years ago, over 10 years ago, there was this review on the subject, which looked at the use of matrix scaffolds and various additions to that, namely renal organoids, recellularized scaffolding where you combine them, the use of stem cells, 3D printing for the matrix, and of course, an on a slide kidney. All of these being to try and deal with renal failure. And they thought that within 10 years, if you look at the bottom, you'd be able to reach a potential clinical solution. Now we're over 10 years down the line and we haven't, because the kidney is such a complex structure that nobody's been able to adequately bioengineer a functioning human kidney. And so certainly this is a conclusion that was reached then and remains now. The next area, of course, from the kidney going down towards the bladder is the ureter. So if one's thinking of the ureter, one's dealing with a tube which has intrinsic peristalsis, if you like, motions which cause vermiculation, rather like a worm moving, to move urine down from the kidney to the bladder. The major problem we have as reconstructive urologists is the middle third of the ureter, because there you've got a difficult area with impaired blood supply, and how do you actually reconstruct somebody who's lost or has got damage to the middle third of the ureter? You can auto-transplant the kidney, of course, down into the pelvis, or you can use a piece of bowel. But the trouble is using a piece of bowel is that you don't get a very good drainage, and you often end up with a rather dilated kidney with subsequent problems in terms of renal function. Over many years, for the rare instances where we meet this, we have used oral mucosa applied onto a mentum as a patch to reconstruct this area with a reasonable degree of success. But clearly, if we could actually engineer the ureter, that would be great. But the trouble is, nobody's been able to achieve this, because you can't reproduce that intrinsic motion in the ureter, the vermiculation. So the jury's still out on that. Obviously, the holy grail would be if you could actually substitute the bladder, because we all realize that if you have to remove the bladder for cancer, for instance, or if you have a damaged bladder, it'd be ideal to be able to produce a new bladder. And certainly there's been a lot of interest in this. There have been models using, for instance, animals such as a rabbit, but the major problem has been encrustation. If you're using any matrix that's placed into the bladder, and so you have to obviously try and apply cells to it. Atala in the States has done a lot of work, and this is using a model which is related, I think it's a model based on the dog. And following on from this, he then produced some work in the human, which was very heavily publicized back in 2006. But unfortunately, the results weren't very good, because what you were effectively doing is producing a patch of tissue. It was only effective in the patients where they put the omentum on to produce a good blood supply, and it wasn't really functional. It was just a patch, rather like the patches we use when we apply bowel to the bladder. We're carrying out an ileocystoplasty, for instance. And it's a very expensive way of doing that. We haven't got long-term follow-up on these patients. In the short term, there's a 56% you can see benefit to the patients in terms of compliance and in terms of increase in size. But really, you've heard nothing further about this. So when you hear nothing further in clinical medicine, it means there hasn't been any long-term success. The reason I show this slide is because, having worked with the histology and pharmacology of the bladder for the last nearly 40 years, we now realize that the bladder is such a complex structure. You have the urothelium, metabolic rate 4 times that of the detrusor muscle, with non-neuronal release of neurotransmitters. You have these interstitial cells going down to the workhorse, which is the detrusor muscle, and of course you've got sensory nerves feeding back to the brain. So you've got to have an innervated structure, a functional structure, and a very complex one with many different types of cell. So really that's the alligator in the swamp, if you like. How on earth can you recreate that using a test tube and a matrix and cells? And understandably, whilst people have talked about this and considered it in more detail, and a number of papers on the subject, you can see here 2016, suggesting what we need to do, nobody has been able to achieve that. Moving then from the bladder to the outside world, the remainder of the talk is going to be talking about the urethra in males and in females. And in women, we're talking about the urethra being a sphincter active area, and of course very important in terms of incontinence. If you could actually do something to augment the urethral sphincter, that would be great. I'll also touch on to the subject of sphincteric weakness, pelvic organ prolapse, and in this context, the ways in which one could potentially consider improving the surgical management there. But first and foremost, let's talk about the male urethra. This is an area where I've been very interested over the last nearly 40 years, carrying out surgery in this area and dealing with urethral strictures. And as you can see on this slide above, urethral strictures are ones where you're dealing with a ischemic area in the corpus spongiosum and the urethra of variable lengths. And the fundamental problem is that you have damage causing scarring and there's poor blood supply. You do get conditions such as lichen sclerosis, otherwise known as balanitis erotica obliterans. You can see a male penis below with the characteristic whitish appearance, and that can produce lengthy strictures in the urethra, as you can see on the left-hand side, with this rather lengthy stricture seen on a urethrogram. Now, there's been an interesting development in recent years, which is a balloon which can be used to dilate a urethral stricture, coated with a compound called paclitaxel, which is an antifibrinolytic. And this is derived from work in vascular surgery where they've used these drug-eluting balloons. The evidence is for short strictures, which have proved resistant to just urethrotomy or dilatation, this can actually produce some benefit. And certainly we have 5-year data from the initial study. It was just in 25 patients. And you can see that there's a 58% success rate by 5 years for short strictures, or just under a centimetre. So a very restricted group, not of course appropriate for those lengthy strictures I showed you. And 14 of the patients did exit the study due to treatment failure. So really, if one's trying to think of bioengineering, a simple area, of course, is to produce a tissue which is like the urethra, like skin, for instance. And we've realized over the last 30 years that tissue from the mouth, oral mucosa, is the most effective way of substituting the urethra in the male or the female. And usually we take this from the cheek, so-called buccal mucosa. You can take it from the lip or the tongue. And what I showed you, that slide with the very lengthy BXO stricture, is one that I've encountered often in my career and had to put in a reconstruction of up to 17, 18 centimeters. I went to a lecture by subsequent colleague and co-worker, Sheila McNeil, who was the first in the world to bioengineer skin, which went into clinical development. And there's a company that does it, that markets this for people with extensive burns. And I thought, well, why not try and bioengineer oral mucosa? And I spoke to her, and the principle is the same: to take a biopsy from the mouth matrix and to grow the cells on the matrix. And that's what she did in the laboratory. There was a research fellow, Saurabh Bhagava, who's now a consultant urologist in India. And this, you can see below, is a bioengineered oral mucosa. And you can see a biopsy taken from there. And on top right, you can see tissue engineered oral mucosa, bladder mucosa versus native bladder mucosa on the left. These cells were grown on a matrix which was from cadaveric tissue through our blood transfusion service, which was thought to be fairly antigen-free. And with ethics approval, in patients undergoing a 2-stage urethroplasty, we actually implanted 5 patients. In 2, there was need to excise part or all of the matrix due to fibrosis. 2 others, there was some scarring which needed to be incised, but with a reasonable outcome, and 1 did quite well. But I decided this wasn't viable as a project. First of all, it's very costly. You need a Class A laboratory to grow the tissue, and you have a window of opportunity to implant it. The patient is ill, or there's problems with the operating list, then you can waste that material, and you can get oral mucosa basically for free. So it didn't strike me that it was going to be a viable option, and we didn't have an appropriate matrix. There had been work with matrices, and there was work again from Atala using a matrix which was seeded with bladder biopsy tissue, and he reported 5 patients with a follow-up of out to 76 months with good results. But we haven't seen any more from this group, so one has to consider that maybe in the long term the results weren't as good as expected. And certainly this was then followed by other work following on from us in Germany. There was a group that developed a bioengineered oral mucosa, and you can see that the initial results, this is from Margaret Fish and colleagues, looked pretty good. But unfortunately, if you look at the subsequent data of 2 years, you can see there was around a 40% failure rate. This is just using symptoms. And remember, with the urethral stricture, you don't get symptoms until the caliber of the urethra is below 12 French. I understand this whole project's been abandoned now. It was being developed as a commercial entity, but unfortunately didn't reach clinical practice. Now, others have looked at matrices, and here's work from Germany, a good friend, Arne Stenzel and his group, where they looked at a matrix seeded with human urothelial cells, and others have done similar work, you can see here, from China, where they've shown this. But it still remains within the area of ongoing research, and I'm not aware of anybody who's developed any adequate product. Now, why just add cells? Why not just use a matrix? Well, my own concern is that if you use just a matrix, you're putting it into an area with a poor blood supply, where there's scarring. And indeed, although people have looked at this, and I gather there's a very exciting ongoing project with European funding, which the EU is also collaborating with, using bioprinting for the matrix, which sounds very, very encouraging. The question is always going to be, the devil's always in the detail. If you look at this as from their website, that you can bioprint what the tissue needs in terms of an appropriate matrix. You can use these various modules. You could produce tubalized structures. Now, a tubalized structure in the urethra doesn't work very well if you use oral mucosa, for instance, because it has to pick up a blood supply, and it can't pick up a uniform circumferential blood supply. So time will tell. It sounds very exciting, this work, and we just have to wait and see, because they'll have to consider growing cells on that matrix. I don't think putting in a matrix by itself is going to be effective. And of course, the best evidence we have in urology always is the EAU guidelines, and you can see that certainly for short strictures, there is some evidence. It's still considered fairly weak that the drug-eluting catheter may well be effective for strictures of less than 3 centimeters. If you think it's a form of crude tissue engineering using release of a substance which inhibits contraction of fibroblasts, in other words. Certainly, we do know that grafts are as good, if not better, than flaps unless there's a poor blood supply. And certainly, the evidence is that use of animal tissues and, of course, just matrices, acellular matrices, aren't to be recommended based on the current evidence in the world literature. And you can see that at the bottom it says, do not use autologous tissue engineered oral mucosa outside a clinical trial. So I've given you the background to that. So let's move on to urethral sphincter regeneration. Now, people have looked at injectables over the last 40 years, and many of the early injectables, if you look at this data from the UK, actually had a lot more complications and cost involved, although they seem to be a simple thing, just injecting a substance into the urethra to bulk up the sphincter. They didn't work in the long term, and there was a lot of morbidity with higher costs in then reoperating on these patients. More recently, there's been an agent Bulkamid, which is a colloidal gel, which has looked very interesting, but in the long term, the data is not as good as other forms of surgical intervention. One of the problems is where you can put an injectable. You've got to get it into the wall of the urethra, which is quite a thin structure, and just doing it fairly blindly or with a crude device doesn't always get you in the right place. It can get you outside the urethra, or you can extravasate into the lumen of the urethral tube. There was interesting work from Innsbruck in Austria, where they're using an interesting device to actually place the material in the wall of the urethra, and there were very encouraging results. But unfortunately, this is a number of years ago, those papers were withdrawn due to concerns about the integrity of the data. Others have been looking at the use of cells injected into the urethra. The same points are, of course, important, getting the cells in the right place. And this is a group, Peters and others, who've been working on this. You can see it goes back quite a long way, this, 2011, and there was a commercial project ongoing. We've heard nothing further, so one has to presume the data wasn't as good as was expected. The reason is maybe a personal bias, but you can grow cells, as in this group, and you can show that they will proliferate if you inject them into the urethra. But ultimately, the urethra is a sphincter, and it needs to have an innervation. And if you inject cells into the urethra, a sphincter in the urethra, how is it going to have a functional innervation? So although you might be putting in an expensive bulking agent, how can those cells know when to relax when you want to void? So that, as in normal circumstances, when you void, you contract the bladder and relax the urethral sphincter mechanism. That is still an unanswered question, because it's all very well growing a tissue, and that's where it struck me the urethra in the male was ideal. It was just a tube. If you're dealing with a sphincter, you need to have that relaxation, the neural input. And that, of course, is another issue when you're trying to grow bladder, you're dealing with a functioning structure like the ureter, or, of course, a very complex structure such as the bladder. So what about stress urinary incontinence, where there is a sphincteric weakness, or there's hypermobility relating to prolapse? And of course, you can have intrinsic sphincter deficiency due to denervation following childbirth or following surgery, hypermobility often associated with prolapse, and any individual patient, you've got a combination of these different factors. So what about dealing with these patients? We're dealing with a dynamic situation, and that's why it's stress or exercise-related incontinence that women experience. We need support of the pelvic organs, the pelvic floor, and we need to realize that it's an increase in abdominal pressure in this dynamic situation, which, if the urethra is weak or the urethra has prolapsed out of the intra-abdominal pressure zone, then you get a failure of equal transmission of abdominal pressure to the urethra, and therefore you end up with stress incontinence. We do know that and there's very few papers on this subject, that if you look at the weakness of the tissues in a person with stress urinary incontinence, you can see that collagen 1, 3, and elastin has decreased as compared to a patient without stress urinary incontinence. You can see all these brownish areas which represent this loss of that normal healthy tissue you see on the right. So, of course, this brings us onto the subject of sling surgery and the use of biomaterials. Of course, you can have synthetic meshes, shown on the left, and the one most people are familiar with is polypropylene, or you can have biological materials, either autologous tissue, the patient's own tissue, xenograft tissue, which is from animals, and over the years I've seen bovine collagen being used, injected into the urethra, or porcine collagen being used as producing materials for prolapse surgery or injected. And of course, you've got then the introduction of the various techniques that everybody's familiar with. So more about that now. There's no ideal material, because with autografts you have to harvest it from the patient, which can leave a tissue deficiency. The problem with xenografts and allografts is that the antigen is not the same as the person you're injecting it into. In other words, you get a T-cell response and rejection. And with biomaterials, you have to have a biomaterial which is well compatible with the tissues, which doesn't break down, and which doesn't cause an undue long-term inflammatory response. Ideally, you'd want a biomaterial which would absorb. Now, if you talk about sling surgery, when I was trained in the ancient days, the slings we used were using autologous tissue put in tight around the bladder neck for a patient with type 3 incontinence, where the sphincter was damaged irreparably, and you wanted to put in a firm support, and often they had to self-catheterize. Over the years, working with colleagues, we evolved the so-called sling on a string technique, just showed to you clinically. You inject lignocaine with adrenaline to reduce blood loss. If you're using autologous tissue, which is what the sling on a string technique is, you can make a transverse incision and then dissect under the urethra. Important to preserve good blood supply and subcutaneous tissues on the vaginal mucosa, and then form a tunnel up into the retropubic space. Harvest a length of autologous tissue around 7 by 3 centimeters. It's variable the length that you choose, with a suture holding it at either end. I usually take this from the rectus fascia, although you can take it from the fascia lata on the thigh. You then, through the incision you've made in the abdominal wall, on the abdomen, forgive me, you can make a little incision over the top of the pubic bone, so you don't have to push too hard with your introducer. Put an introducer in, cystoscope the patient with it in place to make sure that you've not breached the bladder or any other structure, and you can wiggle this just to make sure. And then you can see the introducer below. You can thread the suture, holding your sling on it. So you can do it either side, then pull the material up, and you can suture it in the midline because it's autologous tissue. It doesn't matter suturing it to the vagina mucosa. And then you can close the vagina. And it's always important to put these things in loose, just like the so-called TVT, the tension-free vaginal sling, which isn't tension-free, of course, because the moment you stand up as a patient, then everything falls down and pushes down onto it. So usually I tie it over 2 or 3 fingers, as you can see there. And we had a small paper with colleagues in the UK, not commercially sponsored in any way, although a company did donate Pelvicol, which was derived from porcine material, and we had to abandon this, much to their disgust, after a few months because the results looked appalling, as you can see on the left here. And that is just an important message. Materials over the years have been introduced into clinical practice without preclinical study, and we have had to deal with the consequence of that. If you look at the top slide, though, you can see that we're getting data as good with the autologous sling as with polypropylene, the TVT, and you can see that below as well on the slide just below. And this is 10-year data. So you can see we were very pleased to see this. But of course, autologous tissue you have to harvest. So it's never really caught on, although if you offer it to patients, a proportion will choose that. And the results are very effective. Now, this brings us on to the subject of the use of synthetic material. And we're all familiar with TVT, as I mentioned earlier. That was first used in this context for hernia repair, where complications were experienced. And this led on to then wanting to use material which was macroporous with at least a 75 micron pore size so that macrophages could get through. Now, TVT was introduced, the word work from Ward and Hilton, based on around 200 patients in the group compared to Colper suspension with 2-year data. And the consequence was that all of these materials were introduced into clinical practice based on that limited data and no preclinical testing. And because it looked very encouraging, then it was used for pelvic organ prolapse, and we're all familiar with the consequences of that. And there's been litigation relating to this. Now, don't get me wrong. The tension-free vaginal tape, the transobturated tape, and the more contemporary materials that have been developed are very effective, and they are well accepted by the majority of patients. Erosion, if it occurs, in my personal view, is usually related to technical failure, either devascularizing the vaginal tissue, so you've got a foreign body under it and it doesn't heal, or placing the material partway through the bladder or the urethra and then it erodes through. I wouldn't blame that just on the material itself. In the longer term, though, you do get sexual dysfunction and abdominal discomfort in a proportion. This has been clearly shown. And now there is a view that possibly these materials are producing more inflammation than one would like to see. They're also quite rigid. In the UK and Republic of Ireland and the Antipodes, these materials have been withdrawn from use, which has caused us some clinical issues in terms of finding an alternative. But across the world, polypropylene mesh is still used very effectively, although there are long-term complications. So really the question is, can you choose a better agent, if you like, an evolution, using our knowledge of bioengineering and tissue engineering? At the AU, we set up a consensus group in 2016, which was reported in European Urology, and stated that we needed to look for new devices, but whatever treatment was used, you needed appropriate training. Patients need to be informed because all surgery has complications, and you need to report the complications, which of course all of us as surgeons do find that we don't like to see complications, but it is important to report them. So if you're developing a new material, what scaffold you need, which cells? You can see how that feeds back to the previous talk about bioengineering. What is the response of the cells to the material? What inflammation does occur? And how well is that material integrated into the tissues and remodeled? So the first thing we did, this is about 15, 16 years ago, was to look for a bioabsorbable material. And we looked on the left there at many of the agents that I've mentioned, the porcine material, sheep material, electrospun tissues. And you can see that we elected to, after a lot of work, looked at cell viability, cell attachment, collagen production, elastin production, and tissue properties in terms of tensile strength, and came to the view that the porcine small intestine submucosa was an option, but the best agent across the board was electrospun polylactic acid. You can see a lot of work involved, and sorry to flash through it, but you can see that any of this work involves a lot of basic scientific work, and I attribute this to all the research fellows that have worked with Professor Sheila McNeill. Of course, polylactic acid, is derived from maize, and it's a fairly simple material which is broken down into carbon dioxide and water. So ideal. Microspinning is a technique which can produce materials of very complex structure. It's a very complex process, and obviously this has now been developed into a commercial setting, and many products have been produced which have gone to clinical development in the world based on electrospinning. You can look at the tensile strength of these tissues, and indeed you can also then look at the addition of cells to this. Again, a lot of work, and we, because of our previous work, use oral fibroblasts and adipose-derived stem cells. And the adipose-derived stem cells, in terms of cell attachment, collagen production, and collagen-1 production, and the extracellular matrix quality was better. So with that bioabsorbable and with the adipose-derived stem cells, work was carried out in a model, an animal model, which has been widely used in the field. And certainly you could show that the addition of adipose-derived stem cells to a matrix produced a very reasonable integration into the tissues. You can see on the right there, as compared to the left, very similar to without cells. And the biomaterial used, the absorbable matrix, was well accepted. And you can see, looking at immune response, also very acceptable with good tissue integration, although only short-term data. So if you wanted to go further, you'd need to have longer-term data for obvious reasons. Now, the devil's always in the detail, because the next question is, if you're using an absorbable biomaterial, is it going to, when it's integrated, hang around long enough to actually have enough tensile strength to allow the body to grow into it and to produce a fibrous band, which is what you're trying to do with polypropylene. And you'd wish the polypropylene would go away when you've done that. It's exactly what you do with autologous tissue. When you're putting an autologous graft in, that's remodeled, producing a fibrous scar. And that's how the technique works. Again, there's very little literature on the subject, but we looked at the tensile strengths from the literature in patients with and without prolapse, and based on that, we're able to look at a model. And another research fellow, Altaf Megera, who's a consultant urologist in Sheffield now, actually worked with Anthony Bullock under the leadership of Sheila. And you can see here that looking at the model that they produced, where you're looking at the Young's modulus, the stiffness, you're looking at the tensile strength, and you're looking at the strain at ultimate tensile strength before tissues give way. And unfortunately, if you accept that as being the threshold for healthy paravaginal tissue, from what I showed you in that article, unfortunately, this material failed. It didn't hang around long enough. Another agent has been developed, and I've seen this in the literature, but I think it's actually having the same problems. So we had no option, but obviously to think a bit outside the box. But before we moved on to a non-absorbable material, we also looked at other issues. I mentioned earlier about dynamic features of the pelvic floor. And the trouble is you just grow cells in a static situation. It's not the same as in the body. And so you want to look at the effect of loading on the extracellular matrix production from the cells that you're actually applying to any matrix or scaffold. And you want to look at that in a laboratory situation. Now, the simplest way of doing that is to have a vibrating disc with ball bearings on and the cells there. But a much more robust and elegant model was to spray cells on, you can see with a vital dye there, on a device where the balloon, where they're sprayed onto, you can see them shown in purple, regularly inflates and deflates in a bioincubator. And this very elegant model showed very clearly, as you can see on the right there, production, and green is good in terms of production of elastin, which is what's been stained for here. You can see on the left, over the same time period, just putting it on a balloon which isn't blown up and deflated versus one that is, you can see it stimulates a lot more production. So the idea was, and maybe printing with a computer would be ideal if you can produce a material, is to produce these cells on the material where you could put adipose-derived stem cells in from liposuction of the patient, which of course would be very acceptable. You could do it as a day case procedure and inject them in here, and then you can put in this biomaterial. That obviously didn't come to pass. What about trying to use other mediators to try and augment the material that you're using? And here we then looked at another group within the department, a colleague who's now a consultant urologist in Turkey, developed this. And you can see that if you put estrogen onto a matrix, and polylactic acid was the one I mentioned before, you can see that you get a great deal better vascularization. You can see there on the right-hand side, because the estrogen stimulates the ingrowth of blood cells, blood vessels, and you can see that's shown on the right. Polylactic alone, polylactic acid scaffold alone, and then estrogen plus polylactic acid shown in the greenish color. And you can use an agent such as polyurethane, which I'll complete my talk to mention. And you can see using higher doses of 25 milligrams, 50 milligrams, you get a increasing response. You can see the bottom right here, red is good, the number of blood vessels growing in. So using something like estrogen on an implant in the vagina in a female patient, of course, would probably be perfectly acceptable, because after all, we use estrogen gels and so on. That's something for the future. So it shows the options you have by using a stepwise approach with bioengineering. So mechanical testing is important, and you can see that polyurethane was an agent which we then came down to consider further. What we really want to do, of course, with any material is produce something that mimics native fascia. It's a dynamic situation, so you need to have elasticity. An ideal material should be elastic, therefore. It should be rather like the patient's own fascia with good mechanical properties, if it's going to hang around for years. And it should also be one that integrates well and doesn't produce a long-standing inflammatory response. This is Chris Hillary, who was a research fellow who was working in the laboratory at the time. He's now a consultant urologist in Sheffield. And you can see that he developed this biomaterial in the laboratory, which was microspun, a tri-layer, which has got this random layer in the center with aligned fibers. Random layer there, aligned fibers in the center, are then the same outside with random fibers. The principle is that you want to minimize the foreign body reaction in the tissues. Now, a colleague, Jan de Prey in Nijmegen, Leuven in the Netherlands, who's an international expert on the investigation of biomaterials, very kindly allowed us to look at the polyurethane in a model that his group had developed for looking at the use of polypropylene for prolapse by inserting it into the rectovaginal septum in sheep. And certainly this has been a very interesting model, which showed that 30% of the polypropylene they were looking at eroded in the sheep model. And certainly you can then look at the immune response. You can see here with polypropylene, and you can see what immune response is going on. You can see the fibers in detail. Now, if you look at any biomaterial, you also want, as I've mentioned, consider what happens when you stretch it. And you can see after implantation, on the right here, you can see polypropylene. If you then stretch it, it gives way. It hasn't got that intrinsic elasticity, whereas below polyurethane does. They also then worked in Sheffield, and this was work from colleagues there. This is from Nick Farr and colleagues, this big group, who looked at culturing macrophages on mesh, and they also looked at ways in which you could actually stress polypropylene with hydrogen peroxide and so on. And they have actually done the following interesting work. Now, these are electron microscopy images, and I know the time is short, so just cutting to the chase on this, you can see top there the fibers of polypropylene, and you can see as you come down close-ups shown on the second one, C and D, and you can see here on the left control in E and F, you can see the implanted polypropylene. Can you see the roughness on there? And you can see these little patches, which are cells sticking to the roughness. And you can see that this is shown in more detail below. And you can see after it's been irritated with hydrogen peroxide, how the cells stick on there. So you can see that there is an inflammatory response with cells sticking onto the polypropylene. It's been shown, and it's been reported in recent papers from the group, that you have changes in the surface of polypropylene after being implanted, with splintering of it and potentially oxidization on the surface, although the exact mechanism is still unclear. And so certainly, if you look at the use of, for instance, polyurethane shown at the bottom there compared to others, the key issue is that you're getting better tissue accommodation using various immune histochemical markers. You have to take my word for it at the time available, and this is reported in the literature. Now, taking a leaf from Jan de Prey's group, I worked with a sheep model, which I co-developed at the same time as a group in the States. Same principle of the dissection I showed you in the human, in the sheep, and inserting the patches of polyurethane in exactly the same way. This is published in Urology and Urodynamics. And what we have done from that small series of sheep is to look at, you can see here, TVT, five subjects, 9 polyurethane. And just to explain what this shows, that you've got on the left-hand side A, and this is work which is still not been published, it's just hot off the press, that you've got a marked inflammatory response with TVT, less so with polyurethane. And then if you're looking at 3 months after implantation, this is, and A is at 3 months, and B on the right is at 3 months, you can see that you've got a better tissue response with polyurethane than TVT in terms of remodeling. So this is good initial data, which suggests that as an iteration beyond polypropylene, we're getting a material which might be better accepted by patients. And using the data in the literature, you see Nick Favre, you want to look up his papers, looking at surface analysis, which is really very innovative, using transmission electron microscopy and these surface analytic techniques. You can see on the left from that sheep model, polypropylene with those roughened areas, even at 3 months, polyurethane on the right, no roughened areas at all, and then cutting right down to the bottom. The red is post-implantation versus control at baseline, and you can see on the left polypropylene, which becomes more stiffer. Going to the right is stiffer than the initial implanted polypropylene. Now that's bad to have even stiffer material that's been implanted in a Damex situation. And on the right-hand side, you can see that with polyurethane, it shifts to the left. It actually becomes even more flexible when it's been implanted in these sheep after 3 months. Time will tell whether it is an advance or not. None of this work has been done with any commercial sponsorship. And I'd like to attribute this to all the colleagues on the left-hand side who have been carrying out this work in the Croto Institute in Sheffield. It's based on their efforts, and I'd like to thank the grant bodies that we've received funding from, shown there, without whose support none of this work would have been possible. Thank you very much indeed for your attention, and obviously I'd be very happy to take any questions that you may have.
Thank you, Professor Chapple. A very interesting presentation. And so I now invite anybody, if they have a question, please send it in now. And just while we're waiting for that to happen, just a reminder to everybody that you'll get an email, you'll get a message as soon as the webinar finishes tonight for a survey. You'll also get that via email, so you can choose which one you want to do it. If you do complete it within 2 weeks, then you will get the CME accreditation. We'll send that out to you in about 2 to 3 weeks' time. Reminder also that we'll send you the direct link for the recording for this tomorrow as well to all registrants. Okay, so just waiting for some questions to come in. What's the other thing I need to say? I always forget this at this point. Just a reminder, I guess, to look at the website to look at future sessions. Some registration links are already on there, and also subscribe to our YouTube channel to be notified when videos are available. So I think we've got a question come in. Professor, can you see that?
Yes, indeed. Thank you very much. And I see this is from Uf. The first question is, what are the latest multi-center phase 2-3 clinical outcomes of long-term function and safety of tissue-engineered urethral grafts? To be honest, as far as I'm aware, the last data that I saw was that data from the German group at 2 years. Now, I may have missed a more recent publication, but I'm not aware of any other projects ongoing at the moment. It still is at the stage of clinical research. And then the second question was, since 2023, which biomaterial scaffold design has shown the most robust urothelial integration in large animal bladder augmentation? I've shown you all the literature I can find on the subject, and I think the problem with the bladder, as I've mentioned, is that you're dealing with a very, very complex organ. You're not trying to just produce an organ which is based on just adding one type of cell to a matrix, because that'll be a completely inert, non-functional patch. The bladder is much more complex than that, and my personal view is that it's going to be pretty well impossible. But even if you could engineer a bladder with all those different cell types, which may be possible in the future with new technology and AI and goodness knows what else, how are you going to functionally innovate it? After all, that's what we see in patients with spinal injuries, where you don't have an innervated bladder, and you have a bladder that just does its own thing with consequent damage to the upper tracts. Okay, I've got...
yeah, no other questions at the moment. So just Remind everybody, we haven't got too much time left. So, there's one coming through now from Joseph again.
Okay, this is from, and has the
Joseph Maran.
Optilume future in patients with BPH? Well, it really wasn't the subject of this talk, but I did review a recent paper which was published earlier this year, which suggested that there was some benefit with it. It was with prostates of 40 grams or less, as far as I could see in that trial. It was 2-year data. And all I would say is that, I mean, whilst it's interesting, and what you're doing with the balloon dilatation of the prostatic urethra, or bladder neck, if you like, is you're using paclitaxel to prevent it fibrosing again. Going back into the ancient past, balloon dilatation of the prostate had a time of enthusiasm. A number of devices were produced until a colleague in the States produced a paper showing that the results in the longer term were no different to cystoscopy. Now, I'm not suggesting for one moment that will be the fate of the Optilume for prostate, but I think we need longer term data, and we need to realize that if you've got a bulky prostate, which is there, dilating it, and then using something which stops it fibrosing, where you've produced a commissure, basically incision, commissurotomy, that's not going to take away the bulk of tissue. So my own personal bias would be it may have a limited role for bladder neck obstruction, but I'm not convinced for large prostates it will be effective. But I may be wrong. I have no evidence base to support that.
Okay, so we'll just give few more seconds if there's any more questions. We are pretty much on exactly 7 o'clock European time, so it's good timing. If no one else has any questions, if you do think of a question afterwards you'd like to ask, or if anybody's watching this back later on our YouTube channel, you wish to ask a question, you can either leave it in the YouTube comments, or you should have my email address as well. You can send questions to me and I will pass them on. Okay.
Do my best to answer them, Darren.
Yes, okay, no problem, Chris. That's fine. Thank you. Okay, well, I think with that, thank all the attendees for attending tonight's webinar, and mostly thanks to you, Prof Chapple, for the excellent presentation. And I hope everyone has a really good evening. Thank you.
Thank you very much, and good evening all. Thank you for giving me the opportunity.